So I'm Brenna Bray. I'm the founder, director, and CEO of the Nourished Research Foundation. I'm also an associate professor at the National University of Natural Medicine in Portland, Oregon. I'm faculty on the Bridge postdoctoral clinical research program, and I'm an adjunct associate professor at Nairobi University, both in their clinical mental health counseling master's program and in their psychology department in the undergraduate school. Um, I'm also a behavioral health coach with certifications through the Institute of Integrative Nutrition, NASM, and IIN. I think that's kind of pretty good for my qualifications. So before I start, I want to give a little bit of a disclaimer. This presentation is going to contain content related to oppression, invalidation, marginalization, discrimination, bullying, abuse, and trauma, both generally and specific to populations of racial, ethnic, sex, gender, and socioeconomic status minorities. I encourage you to please take care of yourselves, do what you might need to. Um, do what you might need to take care of yourselves. Feel free to step away, come back, move through the space as you need. So before I start, I'd like to do a little contemplative activity. So if you'll indulge me, if you could maybe just close your eyes, take a moment to get comfortable in your space, maybe connecting with your breath for a moment. And then when you're ready, I want you to imagine that if you're a provider, that you maybe have a patient, or if you're not a provider, maybe that you have a friend or family member who comes to you and expresses negative emotions around their eating. Maybe they share with you feelings of guilt or shame or loss of control. And I want you to think about how you might respond. And are there any follow-up questions you might ask? And then I want you to just notice if any imagery comes up for you around that patient or friend or family member, specifically in relation to their body shape or size, their sex or gender, their race or ethnicity, their socioeconomic status, and their age. And when you're ready, you can open your eyes. Thank you so much for indulging me in that exercise. And we can just kind of take whatever we notice there and just set it aside. We'll come back to it a little bit later. So the brunt of my presentation is going to be sharing information from my postdoctoral research, which focuses largely on environmental factors that experts associate with binge eating disorder. And these turned out to be largely social justice issues. So most of this is published in my 2022 publication titled Binge Eating Disorder is a Social Justice Issue, Findings from a Cross-Sectional Mixed Methods Study of Binge Eating Disorder Experts' Opinions and Experiences on Environmental Factors Associated with Binge Eating Disorder. That's a mouthful, and we'll walk through all of it. If that's going over your head, don't worry about it. I do have a QR code here if you'd like to scan and follow along, or you can just hop on PubMed, put in my name, and that'll pull up all of my publications, but this one shouldn't be too hard to find. Some other publications that we're going to be pulling from that came from this same postdoctoral work. So here on the left, we've got the binge eating disorders, a social justice issue, which I just shared. We also have a publication on mental health aspects of binge eating disorder, as well as clinical aspects of binge eating disorder. There's QR codes if you'd like to access any of those. We also just put out last year a publication from the same study on complementary and integrative health use in binge eating disorder. We're working on a narrative review. And we have 3 publications on treatment access barriers that we're also getting ready to put out. One is from that publication, one is a narrative review, and one is a kind of call to action public policy piece. So now let's get into it. What is binge eating disorder? Binge eating disorder is an autonomous DSM-5 diagnosis. It's characterized by 2-hour binge eating episodes that occur at least once a week for at least 3 months. In these binge eating episodes, individuals rapidly consume large amounts of food, and that asterisk is there. How much is large? Larger than most folks would under similar situations. And that can make the diagnosis fairly challenging in adolescence, in cases of pregnant women, postpartum, things like this. But that's what the diagnostic criteria is right now. So larger than others would consume in the same context, associated with loss of control and distress, as well as feelings of disgust, guilt, or shame without compensation, i.e., purging, laxative use, exercise. And this is really what distinguishes binge eating disorder from bulimia nervosa. And you can see the kind of distinction over here in the figure on the right. Binge eating disorder has 89% co-occurrence with mental health comorbidities. These include substance-related and addictive disorders, depression and anxiety, post-traumatic stress disorder, neurodivergence, including ADD, ADHD, and autism spectrum disorder. There are many others that I could name. These mental health comorbidities often go undiagnosed, and it's thought that in many cases, binge eating is actually used to cope with or mask untreated symptoms. Binge eating disorder also has an 80 to 90% co-occurrence with physical health comorbidities. It has a 40 to 70% co-occurrence with lifetime obesity, 60 to 70% with diabetes, metabolic syndrome, which would include hypertension, hypercholesterolemia, and hyperlipidemia, 66% co-occurrence with cardiometabolic disorder. And it's thought that overweight and obesity may not be health risk factors in individuals with binge eating disorder. Philippa Hay in Australia has, along with her colleagues, have produced some research suggesting that in folks with binge eating disorder, overweight and obesity may actually not increase risk for cardiometabolic factors. Of course, we need more data on that. That's just one study, but I think it's important to acknowledge, and we'll come back to that as well. Binge eating disorder significantly impairs daily life. So it accounts for 0.98 disability adjusted life years per person. So that's 9.8 DALYs per every 100 individuals, zero point 0.8 million dailies total. And that's from the 2019 Global Disease Burden Database published in 2021. It has high lifetime prevalence rates that are estimated at up to 23%. So it accounts for 23.4% of the global population in 2019. That's 17.3 million impacted individuals. And again, that's from the 2019 Global Disease Burden Database. There is some question about those numbers, and I'll address those a little bit later as well. Here's a figure from the global disease burden just showing this prevalence rate. And as you can see, most people, when they think of eating disorders, they think of anorexia nervosa. This purple line here represents anorexia nervosa. Here in orange, we're seeing bulimia nervosa. Here in green, we're seeing OSFED, otherwise specified eating and feeding disorders. And then in blue, we're seeing binge eating disorder. So it is by far the most common eating disorder. A 2024 growth analysis report valued the binge eating disorder market at $0.81 billion in 2024, quote, driven by increasing awareness, advancements in treatment options, and the rising prevalence of the disorder across the 8 major markets. It was estimated to have a 6% compound annual growth rate between 2025 and 2034. And by 2034, it is estimated to have a value of 1.45 billion US dollars. I think this is really important because it highlights not only the growth rate of binge eating disorder, or rather of folks who are recognizing binge eating disorder and taking actions to access treatments, but it also recognizes the consumer and the political aspects of binge eating disorder, that there is a binge eating disorder market, that there are companies that benefit from this market, I think is a very important thing to recognize. Standard of care interventions for binge eating disorder, the APA recommends psychotherapy as the #1 kind of guideline. That includes cognitive behavioral therapy and interpersonal therapy. Medications are recommended for folks who fail to respond to psychotherapy or who prefer medications. These include antidepressants, typically SSRIs, but they can be tricyclic, so escitalopram, sertraline, and then Vyvanse or lisdexamfetamine, which was developed for ADHD, but it is FDA approved for binge eating disorder. It's actually the only pharmacotherapy, I believe, that's FDA approved for binge eating disorder. Other medications that are commonly used, anti-obesity medications like orlistat used to be very commonly used. I believe orlistat has now been taken off the market. Anticonvulsants like topiramate. And then, of course, we're seeing a large insurgence of GLP-1 receptor agonists, which are not approved by the FDA for binge eating disorder, but they are commonly used. They do have a large base of empirical support. That would include things like Ozempic, Wegovy, etc. So those are medications, and then nutritional counseling and behavioral weight loss are also included in guideline interventions for binge eating disorder. One thing that I'll just note here about the third and fourth guideline recommendations, nutrition counseling and behavioral weight loss, is that these are interventions that can be administered by someone with a certificate. So I'd say maybe like low to mid-level providers, right? And it just creates a kind of unique space in binge eating disorder where you have guideline care, includes psychotherapy, which can be administered by a trained therapist. Second guideline, medications, which can be administered by a psychiatrist. And then we have these other guidelines that can be administered by folks who have perhaps a little bit less training and, don't necessarily require having training in eating disorders. Other evidence-based treatments that are increasing in their evidence-based or research as well as in their use are very commonly used include other psychodynamic therapies, so family-based therapy, which we see more in kiddos, pediatrics, adolescents, integrative cognitive affective therapy, and then mindfulness-based interventions. So that would include things like dialectic behavior therapy, DBT, mindfulness-based stress reduction, MBSR, mindfulness-based cognitive therapy, acceptance and commitment therapy, and then narrative-based and humanistic therapies are also have a large empirical base and used. And we're seeing a lot of these interventions being tested and used in one-to-one counseling as well as in guided self-help formats. So things like CBT, DBT, we'll see in guided self-help. Now, the research that we have on treatment efficacy is largely at this point outdated, and we do need updated research. And that's not a knock, that's just an advocate for the needs of the field. But what we find in comparative studies is that these treatments have collectively low treatment success rates, range between 38 to 44%, with high recurrence rates between about 49 to 64%. They also have high rates of treatment dissatisfaction and high rates of early discontinuation of care that do not significantly differ from one another. And again, that's from comparative studies that were done before COVID. Most of this data, in fact, is collected before COVID, as is most of the prevalence data that we have. So we really need updated research on binge eating disorder, on its prevalence, on its treatment efficacy, things like this. And of course, that's being hampered by the current administration with research being defunded and then with eating disorders being a target of research defunding over the past, year to several months. Another really big gap in the field is that of self-recognition as well as clinical detection and care. So the data shows us that most individuals with binge eating disorder don't know themselves that they have an eating disorder. About 95% of folks with binge eating disorder don't know themselves that they have an eating disorder. 95% never receive a formal diagnosis. 95% don't recognize the need for treatment. 56 to 87% never receive standard treatment, and 85% lack access to health care. Now, this is a huge barrier for a variety of different reasons, but one that I'll name here is that historically, especially prior to COVID, most of the research that we have that informs what we think we know about binge eating disorder comes from treatment-seeking samples. And the data that we have broadly shows us that that has low face validity of the full population of folks who experience binge eating disorder. So again, we really need more funding for research that can collect a more inclusive understanding of binge eating disorder. Another gap that we have in the field that is growing in awareness is what we in the field call the swag stereotype or the swag misconception. And this is one that ascribes all eating disorders to, quote, skinny, white, affluent young women or girls, typically with restrictive type eating disorders. So I want you to think back to that contemplative exercise that we did. And I just want you to, kind of remember the imagery that came up for you around that person that you imagined interacting with. And maybe just know if they met that, that kind of swag demographic. Now, this demographic does saturate treatment-seeking populations and samples, again, that research historically recruits from to inform our understanding of binge eating disorder. And that SWAG demographic, I will add, tends to saturate treatment-seeking populations in eating disorders broadly, as well as in mental health and naturopathic and allopathic healthcare. So that's who's using healthcare systems primarily. However, that demographic represents less than 5% of all individuals with eating disorders, and also about less than 5% of folks with binge eating disorder. Here's some publications. There's numerous publications that cite this. I just wanted to include a few here. And here's a quote from an expert in my study. This is published in my 2022 publication. So much of the eating disorder perspective and history that we attend to are very female focused and come out of the female gender orientation. I think anorexia nervosa kind of set the stage for a current understanding of eating disorder pathology and treatment, and anorexia nervosa is so dominantly female. We know that unfortunately, eating disorders have been hampered by these old stereotypes about who's affected, and that leaves millions of people undetected with an eating disorder. So this is really important to acknowledge, and I think there's another quote here. We'll get into another quote on that later. So this swag stereotype, it really needs awareness and dismantling in order to help us really help the majority of folks who are experiencing binge eating disorder. We need updated information on demographic prevalence, risk factors, pathology that include the 55 to 95% of affected individuals who go undetected, unscreened, undiagnosed, and untreated. So now I'm going to kind of get into some of my research on this topic that stems from this kind of landscape that I just, kind of gave an overview of. So in my postdoc, I'll just preface, my PhD is in biomedical science and neuroscience, and that was preclinical. So I was focusing on the impacts that stress hormones have in the brain and the way that stress hormones like cortisol in humans, corticosterone in rodents, can alter reward neurotransmission. So this would be dopamine output in the nucleus accumbens. And in my postdoc, I made a huge leap. Not only did I make a kind of lateral change from the field of the neurobiology of amphetamine addiction and withdrawal to eating disorders, but I also went from preclinical research to clinical research. And in order to enable me to make this transition, I needed a way to get a pulse on the field of clinical eating disorder research very quickly, and also to help establish myself as a researcher in the field. So my postdoc advisor, Heather Zwicky, absolutely brilliant, said, why don't we do kind of a mixed methods qualitative study, almost of a Delphi panel, and we'll identify experts in the field and we can ask them their opinions, perceptions, their professional opinions and perceptions on, all of these different factors related to binge eating disorder. So that's exactly what we did. We developed criteria to identify binge eating disorder experts. This included researchers, clinicians, healthcare administrators, policymakers. The criteria was based on federal funding, PubMed index publications, professional leadership, popular press, and Google ability. So we wanted to include folks who are shaping the field of binge eating disorder, both in research and in clinical care. But we also wanted to capture, if you're Joe Schmo on the street and you have binge eating disorder and you go to Google to find some help, who are you likely to access, Because those folks are shaping the field as well. So we had a broad range of experts here. So our eligibility criteria, we had three different eligibility criteria categories. For researchers, they were required to have at least one active NIH R01 grant or some other grant funding mechanisms. at least 10 last author PubMed index publications in the last 10 years, and at least 5 of those within the last 5 years. We also had some separate criteria for food addiction, and other criteria as well. I'm just kind of highlighting the basics here to give you a picture. For clinicians, that included things like organizational involvement and leadership in professional societies. And then we had a combined category for both. So if someone met, maybe one or two of each of those criteria, they could also be included. So this is just a little kind of Prisma schematic here. We developed this criteria. That criteria identified 38 experts globally, 18 who met the research criteria, 18 who met the clinical criteria, 2 who met the dual criteria. We invited all 38 to participate in this research study. 24 were excluded. They either declined to participate or did not respond to, I think, 5 or 6 emails and outreach. 14, though, did consent to be interviewed. So they underwent 2-hour-long, semi-structured, anonymously recorded Zoom interviews with myself. So we started recording after introductions to protect the anonymity of the individuals. And as you can imagine, 2 hours is a huge amount of time. I am so grateful to the folks who agreed to participate in this study and donate their time. So generous. I was able to ask them really everything about binge eating disorder, from pathology to treatment to clinical factors. Skipping back, so the participants included 7 who met the research criteria, 6 clinicians and healthcare administrators, 2 who met the combined criteria, and 1 who actually met the research and clinical criteria. A little bit of an overachiever. Again, I was able to ask these folks everything under the sun about binge eating disorder. And just an example question here, please describe your literature and research perspective or knowledge of findings, current clinical guidelines, and your own personal or professional experiences that relate to binge eating disorder pathology and treatment, right? So that is a big question. And then we kind of broke it down, and there were smaller questions that followed. So we kind of went through these interviews, and then the interview transcripts were qualitatively analyzed for themes by myself and Dr. Zwicky, who is a co-investigator on this study, as well as my postdoc mentor, really the grandmother of naturopathic research. We used a process called reflexive thematic engagement. So we just go back into the transcripts, identify themes. We met, kind of discussed the themes with one another, and then we went back into the transcript, to kind of confirm. So it's a really reflexive process. Themes and sub-themes that were identified have then been explored, and we've published 4 of these in the publications that I've already named, but I'll go through them really quickly. So the first, if you get the PowerPoint, you click on these, they'll open up to the publications. The first addressed environmental factors associated with binge eating disorder. That's what I'll be presenting on today. Second, addressed mental health aspects. Third, addressed clinical aspects. And again, we've also addressed complementary and integrative health use, as well as treatment access barriers. So we're going to focus on environmental factors. These were largely social justice issues. Only one of these had I actually predicted going into this study. So 12 primary themes were identified, and these included systematic issues and systematic oppression, marginalization and lack of access to resource, gaps in clinical research and care, invalidating environments and experiences. Those 4 themes were spontaneously endorsed by all experts, meaning that all experts addressed these without prompting. I didn't ask, what do you think about systemic oppression in binge eating disorder? I could not have imagined to ask that. But every single expert discussed this. Other themes included economic precarity, endorsed by 93% of experts, stigmatization and discrimination, trauma and adversity, food insecurity, interpersonal factors, social messaging and social media, nutrition scarcity, and predatory food industry practices and environments. And that last one is the only one that I had predicted. So as you might imagine, the rest of this presentation is going to be not all rainbows and unicorns for a little bit. But I think these topics, these themes are really important to address. So we'll start with the first theme of systematic issues and systems of oppression. There were many different sub-themes identified within this theme. systemic discrimination, including discrimination around body, weight, shape, and size, as well as structural racism, structural sexism, social media and sociocultural ideals, insurance and healthcare systems, predatory food industry practices and environments, abuse, which can include sexual, emotional, and physical abuse, geographic systems of oppression. So if someone lives in an area where they don't have good access to healthcare broadly or eating disorder healthcare or government assistance, clinical factors in the field of eating disorders, which include issues of justice, equity, diversity, inclusion, access within healthcare systems, as well as kind of an anorexocentric thinking, which we'll touch on later, federal funding for binge eating disorder research. And remember, these interviews were conducted in 2021 to 2022, and I think this is one of few publications where these issues are more relevant today than they were then. Economic exploitation, school systems, legal systems, police harassment. So here's a quote from one of the experts. How we think about eating disorders is that anorexia was kind of the granddaddy, the thing we knew first. And then bulimia kind of grew out of that next. People used to refer to it as failed anorexia. And I would say that in part, binge eating disorder was thought of initially as being like bulimia, but without the purging. So the same mechanisms. And I would say that traditionally, when I'm talking to my colleagues in the eating disorder field, the dominant mechanisms that have a tendency to be most thought of are things like restraint and shape and weight overvaluations. So food, eating restraint, body shape and weight overvaluations. But there's starting to be a bigger push to have a more encompassing view on mechanisms like reward, inhibitory control, emotion, distraction, things like that. I think in part because the restraint stuff wasn't necessarily panning out with binge eating disorder quite as well. So that's just one perspective, one quote from one expert, but I think it really highlights an important point. So why am I showing you a dolphin? Well, one, when you show scenes of nature in a presentation, it helps lower cortisol levels, but that's not the real reason why. The real reason why is that it can be easy to associate binge eating disorder very strongly with anorexia nervosa and bulimia nervosa because they're all feeding and eating disorders. I'm going to introduce another quote from a participant, and this quote that this participant shared was actually in relation to a different question, so I'm using it out of context here, but I think it's equally relevant. This person said, I think in mental health, a lot of what we do, we see commonalities behaviorally, superficially, and then we make deductive applications. But dolphins and sharks look and behave quite similarly, but one's a mammal and the other's not. If you look superficially, a lot of things can look the same. But I think we need to try and understand these more completely to see if such apparent commonality is supported. We need to review the data. And I might add, we need better funding to collect more data. But I think this is so important in the field of eating disorders broadly, and especially in binge eating disorder. My opinion, my perspective, and what I glean from my interviews with these experts, the field of binge eating disorder is highly heterogeneous. There's a lot of variation in what can cause binge eating disorder, and it's also highly nuanced. And while it can be easy to read a title of a publication or go on LinkedIn or social media and follow a person who is very confident, I think what we really need to be doing is going onto PubMed and taking time to really parse out all of the many factors involved in this issue. So theme number 2, marginalized and underrepresented populations. Again, this theme was endorsed by 100% of experts without prompting. Sub-themes included low socioeconomic status, economic precarity or insecurity, food or nutrition scarcity, which were both primary themes on their own, the male sex or gender orientation, racial and ethnic minorities, age, and religion. So we talked about the swag stereotype that ascribes all eating disorders to thin, young, affluent, white women. The reality is the data that we have shows us that actually marginalized individuals, specifically folks using government assistance, members of the BIPOC and LGBTQ2+ communities, have 2 to 3 times higher risk and prevalence rates of binge eating disorder than their white, cisgendered, heterosexual, affluent counterparts. So members of the BIPOC community have 2-fold higher risk and prevalence rates of eating disorders than their white peers. yet they are 50% less likely to be screened, diagnosed, or receive care for an eating disorder, and they're represented in less than 10% of research publications, as well as less than 10% of research samples broadly. Members of the LGBTQ2 plus community also have almost 3 times greater risk and prevalence. So sexual minorities have 2.75 times greater risk and prevalence of developing binge eating disorder. So gender minorities, we see 70% prevalence in eating disorders, 30% in binge eating disorder prevalence. So here's a quote from an expert. If you're a Black woman, if you're somebody who lives in a larger body, if you are an older male, people aren't going to think that your eating habits constitute an eating disorder because you aren't a young, thin, cisgendered white woman. I think it also makes sense to talk about the specific ways in which underrepresented groups might be struggling that are unique to them and their experiences, rather than just saying anyone can be affected. So knowing, for example, that if you are a sexual or gender minority, you are at much greater risk of any kind of eating disorder behaviors. Knowing that if you are a member of a BIPOC community, you are very unlikely to get detected with an eating disorder. And that means you could struggle for a long time. And what do we do then to reach these communities in a way that's meaningful? So another theme that was identified outright as a primary theme, but is also representative of a marginalized community or population, are folks with food insecurity, economic precarity, and nutrition scarcity. Now, I'll add that in my 2022 publication, we kind of grouped these all together in one theme. Since then, we've done secondary analyses, and I think these really deserve to be themes separate of one another. But we'll kind of group them together here. So food insecurity increases risk of binge eating disorder 1.65-fold. We have data showing that using government assistance before the age of 18 increases the risk of binge eating disorder 3-fold. We also have some amazing studies that come out of 2 different food pantries in San Antonio, Texas. These studies were conducted between 2015 and 2016, and they found that 52% of individuals using food pantries reported restricting their food or eating or fasting for more than 8 hours. 52% also met diagnostic criteria for an eating disorder, usually binge eating disorder. This correlated significantly with increased weight and BMI, as well as increased eating disorder pathology. So you can see the Pearson correlation coefficient 0.25 with a p-value of 0.0001. So very high confidence in this correlation, which is not insignificant. So here's another quote from one of the experts in my study describing what patients would say to them. Well, yeah, I have binge eating disorder. I binge eat the first 2 weeks of the month because that's when we have food in the house. And then there's no food in the house the last 2 weeks of the month. So one, I want to make the point that these findings from these 2 food pantries in San Antonio, Texas, reflect findings that we've seen in studies done in food pantries nationwide. I think there's a study that's been done in Georgia and somewhere else in, Jordan and somewhere else in the Middle East. I can't remember off the top of my head. But this is not these are not isolated findings. Now, when these individuals were asked why they were restricting their food in this San Antonio study, which I think is a brilliant way to design this study, the 3 reasons that they most commonly reported for restricting their food were 1, insufficiency, stretching food to make it last. So this is someone who knows that their food allotment is insufficient and they're doing the best they can to make it work. 2, prioritizing other family members. So minimizing hunger for other family members. So this would be like a mother who's trying to eat less, or a father, a parent who's trying to eat less so their children can have more. And 3, prioritizing medical expenses. So diapers and tampons over food, right? Now I want to make the point, this is not the story of someone who just needs to love their body more, of someone who's trying to control their food and eating to control their body. This is the story of someone who is experiencing insufficiency. And they are making a distinct cognitive choice, a cognitive strategy on how to manage that. This is perhaps not someone who's going to benefit from one of our traditional eating disorder focused cognitive behavioral therapy treatments. They're not going to benefit from a solution that teaches them body acceptance necessarily, although those can both help, right? But this is a good example, I think, where in the field of eating disorders, often, and I'll touch back on this later, we place the responsibility so often of eating disorders on the individual, when often I think the responsibility largely is that of the environment, and the individual is experiencing that. And I think that to not recognize that does a disservice in many cases to individuals who struggle with binge eating and binge eating disorder. So another theme that was identified was stigmatization and discrimination. There were several forms of stigmatization that were identified by experts. This included body weight, shape, and size stigmatization, stigmatization around having an eating disorder, around having a mental health diagnosis. And here's a quote from an expert. "I have a patient with binge eating disorder whose doctor told her, quote, 'You're fat every day, so you should exercise every day.'" That's from a healthcare provider. But that's really what we're telling people as a culture and society. The practitioner just put it into words. Sources of stigmatization that were identified by experts in this study included sociocultural, right? So we have stigma in our society, in our culture, in the social media around binge eating, around certain body weight shapes and sizes. These were also internalized. Stigmatization was experienced by patients themselves. Most notably, they occur among healthcare providers and in healthcare systems. And I'm reporting results from experts. The impacts of stigma cannot be understated. They include shame, trauma, and adversity. They can really be expressed as adverse childhood experiences and adverse life experiences. They can lead to PTSD. They can result in poor self-esteem, interpersonal relating, isolation. We know that they contribute to about 83% of variance in binge eating disorder. They can contribute to the development of binge eating disorder, and they can result in healthcare avoidance in 90% of adults with binge eating disorder, all of which worsen mental health. So finishing another quote here, "If the eating disorder has been associated with weight gain, then we know for a fact that the individual has been intruded upon by families, doctors, institutions, and there's trauma associated with that. There's trauma associated with being told day in and day out that what you are is not acceptable or lovable or okay. Many people who are living in larger bodies have been teased or bullied around weight. So there's a lot of trauma associated with binge eating disorder. I'm going to come back to that at the end, but I just want to offer here, if you are a provider, a mental health provider, a primary care provider, whether your patient has an eating disorder or not, if your patient is living in a larger body and you feel it important to discuss that with them because it can increase risk for other health issues, hypertension, hyperlipidemia, heart disease, please do so with sensitivity, empathy, compassion, and caution, knowing that you are going to be walking on a battlefield. Please maybe slow down when you have these discussions. So a final point that I'll use to emphasize stigmatization. I've read this quote already. If you're a Black woman, if you're somebody who lives in a larger body, if you're an older male, people aren't going to think that your eating habits constitute an eating disorder because you aren't a young, thin, cisgendered white woman. Now, one of the things that we do at Nourished is we seek to shape and change the environments that eating disorders occur in. So we invest a high amount of resources into social media campaigns, public outreach, public speaking, things like this. This was one of the first infographics that we posted on, we have a Instagram site, Facebook, and LinkedIn are the three social media outlets we primarily use. We posted this infographic on Facebook or Instagram. As you can see, we had 129 responses, 68 comments, 4 shares, over 1,000 folks who viewed this. And so we published this. I was thinking, that's great. Folks are engaging. And then I read the comments. And the comments were atrocious. There's no better way that I can share with you what the stigmatization is like than sharing these comments. And there's no thing that I would rather do. Stop eating like a pig. Put away the KFC. Just horrible, horrible things. I saw these comments. I met with Barbara Callew, who's our social media manager, a brilliant young woman getting her master's in clinical mental health at Johns Hopkins. She created this. I was devastated. We discussed how to handle this. We turned off the comments. I'm thinking we're just enabling this. And Barbara asks very quietly, would you mind if I have access to some of those comments? And I said, no, absolutely, go for it. So our next meeting a week later, Barbara comes back and we have our meeting, we're talking, and at the end of the meeting, she says, I developed our next social media post. It's a reel. Would you mind if I show it to you? And I said, please. And so here's what Barbara created. All of the comments that you see on this reel are real comments that real people posted in response to this infographic, which largely have nothing to do with the content of the infographic. Anytime you're given the message, overt or covert, that something is wrong with you, like you're big, you're too much, you're repulsive, you're gluttonous, you're bad, whatever. That's really the message that people internalize through a lot of experiences with healthcare practice, practitioners, families, schools, etc. I want you to just think about what that experience might be like for you if you went on social media and you lived in a larger body, and that's what you were met with day in and day out. And you went outside on the street, and that's what you were met with day in and day out. The impacts of stigma cannot be understressed, and they are not the responsibility of the individual. And they also occur in our healthcare systems. So moving forward, let's see, we're at 9:45. I'll go maybe 5 or 10 minutes more, and then of course leave time for questions. So trauma and adversity was a theme that was identified by experts outright. Now, this can include kind of conventional adverse lifetime experiences, ALEs, and adverse childhood experiences, ACEs, that we're seeing over here on the left. So things like abuse, neglect, household dysfunction, physical, emotional, sexual abuse, physical and emotional neglect, mental illness in the household, incarcerated relatives, interpersonal violence, substance abuse, or divorce in the household. But these can also include what Kronholm and others identify as non-conventional ACEs. But first, I'll just focus on these conventional ACEs. So we have data showing that a single adverse childhood experience, especially involving restricted food access, so food insecurity, increases odds of developing binge eating disorder threefold. So the adjusted odds ratio of 2.95. That's from Cafino 2020. We have numerous data showing the impacts of trauma on the brain. So here you're seeing a PET scan of a healthy brain. Here you're seeing a PET scan of chronically institutionalized Romanian orphans, showing the impacts of extreme infancy deprivation on the developing brain. This is kind of one of the better known studies on the impacts of trauma, adverse childhood experiences on the brain. We now have numerous data supporting this. What I want to highlight is that these can also include unconventional adverse childhood experiences and adverse lifetime experiences, what we might call expanded ACEs. So things like food insecurity. The percentages that you're seeing here are the percentages of experts that endorse these. Food insecurity, invalidation, oppression, marginalization, oh, excuse me, let me go back, body weight, shape, size, stigmatization, mandated movement, chronic dieting, untreated mental health illnesses. So this is from a meta-analysis. If you're freaking out, don't worry. What we're looking at here is an odds ratio. Over here on the left, we're seeing all of the case-controlled studies on childhood adversity and psychosis broadly, not specific to binge eating disorder. So you can see there are many studies here. And the odds ratio is 3.49, meaning that childhood adversity or having an adverse childhood experience increases the risk of psychosis almost 4 times, 3.5 times. So this is just in case-controlled studies. And here's the data. I want to make the point, so what we're seeing is an expansion of this down here, up here. Now, if you look at this scale, I want to make the point that this is an exponential scale. It's not linear. So if we were to make it linear, this is how far out, right? So almost 4 times. This is in case-controlled studies. And again, we also have data in cross-sectional studies. Here's what we're seeing in cohort studies. And in all studies, the odds ratio is 2.8. So adverse childhood experiences increases risk of psychosis almost 3 times. That's probably the most science you will get. Thanks for hanging in. We also have data identifying neural correlates of a variety of different types of adverse childhood experiences. So here we're seeing Nicholson's 2022 systematic review of neural correlates of sexual minority stress. You can see that, let me go back. We can see that the default mode is impacted. So we see alterations in self-referential processing, social cognition, sense of self and identity. The salience network, so the way that we value things is impacted. We see changes in threat detection, hypervigilance, which are directly relevant and observed also in binge eating disorder, stress reactivity, defense and fear processing, emotion generation, interoception, so our ability to perceive information from our internal receptors, network switching, avoidance, of course, reward sensitivity and regulation, and then changes in our central executive network. So emotion dysregulation, executive function, emotional awareness, things like this. Again, we have numerous data showing the impacts of adverse childhood experiences also on adult obesity. And this is from a meta-analysis conducted by my colleague David Wiss and Timothy Brewerton, published in 2022, showing adverse childhood experiences, the relationship between adverse childhood experiences and and obesity. And again, adverse childhood experiences increase the risk of adult obesity almost twofold. We started gaining information on this work back in the late 80s, early 90s with Vincent Folletti's work. Vincent Folletti was really who established adverse childhood experiences, ACEs, and the ACEs scale. He was an obesity researcher and clinician, among other things. He noticed that when he was doing a weight loss trial, folks would get down to, quote unquote, a healthy weight maintenance, and they would drop out of the study. So he did a follow-up and asked folks why they were dropping out of the study. And what folks largely reported was that they began to feel very uncomfortable as they reached a normal body weight. Perhaps it reminded them of the body weight, shape, or size that they were in when they experienced a trauma in their childhood. Largely, the reasons they felt uncomfortable were linked to trauma. Most of these folks had adverse childhood experiences, often sexual. And they would say things like, I felt very uncomfortable being in the body that I was in when I was abused, or I began to receive a lot of attention and being looked at, and that felt very unsafe to me. So for a long time, we had a mechanism or a theory, this protective measure theory that associated childhood abuse with obesity, and it was thought that obesity served to help these folks feel safe and protected, whether it was an intention or not. We have data now showing that while that may be true, there are also many other biological mechanisms going on. So I'm showing childhood sexual abuse here on the left, but any type of childhood adversity we know activates, changes immune function, It can cause immune stress responses to go from being anti-inflammatory to pro-inflammatory. It increases allostatic load. It can result in dysregulation of the stress system, so the hypothalamic pituitary adrenal axis. It can cause epigenetic changes. It can cause changes in brain structure and function, as we just showed. It can certainly alter reward sensitivity. And all of these things together can significantly increase risk, not just for obesity, but also for a variety of eating disorders. It can also increase consumption of processed foods, which can increase risk for highly ultra-processed food addiction. Food addiction is not a clinical diagnosis, but it is a very well-validated clinical construct and concept. We have operational definitions. I'm happy to answer that in questions, but for now, I'll keep moving along. And I'm going to kind of land the plane here. So I'm going to skip through some of this. I do want to, I'll just skip through this and we can address this later. One thing I want to point out is that a lot of these themes interact with each other, right? So invalidation, marginalization, stigma, discrimination, trauma, adversity, interpersonal factors, social messaging, and social media. Generally, if you experience one of these, you experience more than one of these. And these are going to walk someone very quickly down a path of an eating disorder. Try to move along here. Let's get to, excuse me. Okay, here we go. So a real quick thank you. You're seeing a picture of Barbara Callew on the left. Barbara is a clinical mental health counseling master's student at Johns Hopkins University, We're so grateful to have her on our team at Nourish. She manages our social media, and she's created all these beautiful infographics that you see here. Qualitative research like mine, I think, is so deeply important. It helps us really understand the quality of these things. It helps infuse heart and soul into them, but they can be very challenging to communicate visually. I've done this before, Barbara, and I don't do a great job at it. My PowerPoints are really an eyesore. So Barbara's created all of these infographics that I'm just so grateful. It makes it really makes it much easier to communicate these findings. Rishi Lamashane is another of our students at, or sorry, our research interns at Nourished. He was accepted into Brown University's master's program of public health. I believe that he's deferred to another year. Rishi came to me and he was interested in biostats. And I said, I don't know anything about I know only as much biostats as I need to know to teach to my students, but I know how to mentor you in learning about biostats. So Rishi brilliantly took this network mapping kind of concept that we use in neural network mapping and things like this, social network mapping. He developed a protocol to apply network mapping to the environmental factors that we observe in binge eating disorder. He did this not once, but twice. He developed a protocol in Kumu and in Python. What I'm going to show you is some of the findings from Kumu here, and it enables us to really see how interrelated all of these things are. So in blue, you're seeing the primary themes that were identified by experts, shown here on the right. In green, you're seeing sub-themes. And I'm going to kind of breeze through this because I've got about 5 minutes left. To my credit, we did start a little bit late. But again, so we're seeing the themes here. When I kind of put these in Kumu, first what I did was I entered in 3 domains: mental health, physical health, and social health, which I'm kind of calling synonymous to public health and welfare. Now I added, because I can, something that I think might be a biomarker that links all of these things together, and that's the field of psycho, neuro, endo, immunomicrobiology. So there are certain, kind of factors that we can test. Things like morning cortisol levels, things like gut microbiome changes, things like CRP, C-reactive protein, to test immune function, right? And I think these might give us really strong indicators of how all of these things interact, as well as predictors. And each of these in their own right are kind of empirically validated already. So this is kind of how I started in Kumu. And then I added in our themes. And one thing that you'll notice is that when I did this, and I added in our themes manually, but I did them in accordance with how they were described by experts. These all sit much closer to the realm of social health and public health. So gaps in clinical research and care, invalidation, marginalization, systemic oppression, economic insecurity, food insecurity, nutrition scarcity, stigma, right? Many of these things are social health issues that then result in mental and physical health issues. Here I just kind of stretch things out so you can see all of the interconnectedness here. Here's just the themes on their own. Here's the themes with all of the sub-themes in here. Here's all the sub-themes in this kind of domain structure that I created. Some of the themes and sub-themes, so taking and understanding the narrative and lived experiences of individuals with binge eating disorder, that was a sub-theme. It was the most commonly endorsed gap in clinical care and research. I put that over here on the other side because that relates more to mental health. That's something that providers can do. There are other ones that I could have added there as well: stigmatization in healthcare systems, etc. But I didn't get that far. I'm sorry, I'm trying to go back here. Okay. So then I, kind of added binge eating disorder to the center. This was just a reconfiguration, playing around with different ways that we can express these. Here I changed the theme of gaps in clinical research and care to purple. Again, though, what we're largely seeing is these themes are so interconnected and so interrelated, right? We did a social network analysis, and I'm not going to go through these findings because I know we've got like 3 minutes left. But I will just say largely, so if we look at MICMAC influence, which is a systematic analysis metric that explores element exposure, so how exposed these themes are, and their influence, so MICMAC influence, the influence that these themes have on one another. The themes with the highest influence were systemic oppression and systemic gaps, justice and legal systems, which was endorsed by 7% of experts, but had a Micmac influence value of 0.89. Economic insecurity, insurance systems, Micmac value of 0.85, and food industry, predatory food industry practices. Now, I highlighted ones that we, in my opinion, subjectively, have the potential to change and move the dial on. Insurance systems, predatory food industry practices, interpersonal relating. And again, this does highly align. Interpersonal therapy is guideline therapy for binge eating disorder. Nutrition scarcity, federal funding for binge eating disorder research, gaps in clinical research and care, and stigmatization in healthcare systems and among healthcare providers. So I'm just going to kind of breeze through and we'll land the plane here. So what can we do? What can we do for binge eating disorder, for eating disorders, for everyone? Number one, tabula rasa, blank slate. Forget what you think you know about eating disorders. We need systematic screening, detection, and diagnoses among healthcare providers, especially in marginalized populations. If you're a provider, your CMS, your Medicaid, your Medicare patients, absolutely be screening them for eating disorders. We need a better understanding of weight bias and weight stigma and weight discrimination, including patient experiences and impacts. Excuse me. Excuse me. Including implicit weight bias, stigma, and discrimination in the field. So one more quote. This is from an expert. Weight bias affects researchers and clinicians in the field of eating disorders in the same way it affects everyone everywhere. I thought I was not weight biased, but somebody who focuses on weight bias professionally said to me, well, of course you have weight bias. Everyone has weight bias. So I've thought about it and I realized I do have weight bias. It's so much a part of the scenery that you don't even recognize how much it affects how you perceive things. I think there's a lot of people who don't recognize that. So I invite you to just take a moment, non-judgmentally, to consider how weight bias might show up for you, whether you're a provider, a person, a researcher. Taking and raising patient narratives. I think we need to be taking account of people's narratives and life experiences, and that should be informing our therapy and our therapeutic approaches. What I might say this looks like, and I think this is in another slide. Yeah, it is here, so I'll just move forward. Listening to patients, identifying how to listen for what people are telling us about their experiences, and also what they might not be telling us about their experiences. Listening to and understanding unique experiences of individuals with binge eating disorder. Relying on qualitative research. One benefit of the COVID-19 pandemic was that we had a little bit of a firewall between research and treatment centers. We saw a lot more inclusive research and a lot more qualitative research that helped us really gain, I would say, more accurate understanding of what binge eating disorder really is for most folks. We need more accessible and inclusive treatment options. So we need research on treatment options that are low cost, free, virtual, socioculturally sensitive, inclusive, responsive, and also sensitive to the experiences that are unique to folks with binge eating disorder. These need to be options that can overcome treatment barriers, so they can overcome treatment non-responsiveness, lack of access to healthcare, lack of a formal diagnosis, stigma, and even lack of recognition of binge eating disorder. Little spoiler alert, I am a strong advocate of 12-step interventions. We do have some empirical support for these interventions. Largely, we need more. They are curiously underfunded in the field of eating disorders relative to the research and the funding that we see for 12-step interventions in other fields. And I think I'm at my time, so I'm going to just kind of land the plane here. And I'll maybe take a minute or two of questions. I do want to add, though, okay, oops, I'm going the wrong way here. So I think this is important. What can we do as clinicians? One, social justice therapy, integrating psychological counseling with commitment to social justice, equity, diversity, inclusion, and access. Two, focus on inclusive space, emotional navigation, addressing systemic issues, and empowerment. Trauma-informed therapies, recognizing the pervasive nature and impact of trauma. Asking not what's wrong with you, but what has happened to you? What has your experience been, and how can we help? Focusing on safety, understanding trauma, empowerment, healing, and avoiding re-traumatization. And then brilliant sanity, basic sanity and brilliant sanity. These are Buddhist-informed contemplative counseling perspectives. Dr. Kaklauskas has agreed to speak. He will be speaking at 11 this morning, as kind of the SME on brilliant sanity. Very briefly, brilliant sanity acknowledges the basic sanity, capacity for healing, self-awareness, and growth in all of us. It posits that all of us, underneath all of the layers that we pick up in this material world, have a core that is brilliantly clear and brilliantly sane. And from that core, all of our thoughts and behaviors stem, and they are brilliant, they are sane, and they can absolutely be trusted. A brilliant sanity perspective on eating disorders might look at an eating disorder and say that is a manifestation of your brilliant creativity in using the resources you have access to get the soft parts of you through a very harsh environment. And that doesn't mean, oh, you should be satisfied with living with these behaviors. No. But it means you can trust yourself. You can honor the way that your brilliant sanity shows up for you. A simple act that we can take align with this is person first language. So not, anorexics, but folks who have anorexia, right? Things like this. And I think I'll land the plane there. Once again, this is really largely what we try to address at Nourished. I'm so grateful for everyone being here. I've gone 5 minutes into Wendy's time. So maybe if you add questions in the comments, um, I'll be happy to kind of respond in the comments and I'll hop on at around noon. I'm going to just hard give the stage directly over to Wendy. Really quickly here. 1 second. Okay.
Brenna, I love the concept that you just ended with, the brilliant sanity concept. It reminds me a lot of some ideas that I kind of had early in my career, which is that it's really similar to this idea that we're all born with this essence, and like the essence of who we are is like basically we're good, you know? We want to love and be loved. And there's really a drive for development and creativity and connection that's like very healthy, like within all of us. And then life happens and layers form. But what I like about that idea of brilliant sanity, or just like paying attention to the essence, what I really like about it, and I think has a really practical application to our work. Because whenever I give a talk, I'm always like, what's a practical, like what are people going to take out of
Yeah.
this that I hope that will take out of it? And I think what that concept of essence, the purity of our essence, is just something I've always thought about, or brilliant sanity. I've never heard the term, but it conveys that we actually believe in the health of our persons that we're working with. We don't see it also as hierarchical, like, yeah, I'm Dr. Wendy Oliver Pye and I'm a doctor, blah, 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 blah. But I'm really human I'm just really another human being trying to get by. And like humility is like, you're no better or worse than anybody. We're all just like getting by. And one person may have different layers of defenses tied to trauma, and like you talked about ACEs, but we're all just trying to get by, and we're all pretty darn good. We just have different ways of coping and surviving. But as we really heal folks, like the health and goodness that's in their soul, their essence, whatever you want to call it, brilliant sanity, it's there. It's
Yeah.
really just there. What I like about it is it's not hierarchical. It's not like I know more than you. I'm better. You're an unhealthy person. You have an eating disorder, so you're psychologically unhealthy. And I don't have an eating disorder, so therefore I'm psychologically healthy. Like that kind of thinking, I'm just like
Yeah.
blows right
Yeah.
past that. But anyway, thank you for that. That was really fun and
Yeah.
interesting. And I
Thank you.
have some ace slides, so I can just breeze through them.
Perfect.
Right? I could just breeze through them because you already got me covered there. So that's
Excellent.
really cool.
Yeah.